Now we're going to talk about unintentional weight loss in the elderly or older adults. Again, this is a primary care, family medicine, general practice, general medicine kind of approach. Now, I need to say that because if you're expecting something that sounds like a systematic review article or an internal medicine or a clinical pediatrics textbook, start with like really short epidemiology, if you recall your textbooks in medical school, and then a whole bunch of pathophysiology, and then you go to the workup and the tests and things like that, and then you come to the final part. Sometimes it talks about things to consider aside from the hyperclinical stuff. Then we don't do that. We're not going to do that for this session. We're not going to do that right now. Usually when you look at the journals of generalist care providers, what you'll see is an attempt to update everyone so that they end up doing a fairly decent job in approaching a huge array of different medical problems. So it's not going to be hyper specialized because it's not specialist medical care. Anyone can go through your clinic, from a kid with emotional problems to eating problems to an ear infection to an elderly who's dying, or an elderly who's losing weight, or someone who broke a bone, or someone who's having chest pain. I mean, that's how it works. Now, the textbooks are by nature very systematic and very structured because that's the only way you can present a huge amount of knowledge in less than a few thousand or a few hundred pages, right? If you want to have a clinic and then all you see are cases which require you to go through all the details of each chapter for that particular case, then that would be a specialist clinic. Why? Because all the soft, non-specialist looking stuff already got filtered by the generalist healthcare provider or the primary care provider, and it got sent to you. Of course, you don't get to see a whole slew or a whole variety of cases. You get to see the cases that you're specialized in, right? So if you're an eye specialist specializing in the back of the eye or the retina, then they'll send you a whole bunch of retina and eye stuff. You won't see broken bones and things like that. So but you can apply a really hyper-technical reference material onto your case. It's a different context. It's different. Okay, so anyway, so first contact. When we talk about unintentional weight loss, usually there's a variety of ways it can present to you. Most of the time, it presents late. Like if you look at the definition, it's someone who's above 60 or 65 years old, depending on what country you're in or how they define older adults or the elderly. It actually depends on the life expectancy of that place. You know, if the life expectancy is like 63 or 64, if you define it at 65, there's not a whole bunch of people left for you to take care of, and the debility and all the issues happening at 65 and older in developed countries are actually happening at 60 and older, or even at a lower age range in developing or poorer countries. Anyway, so old people presenting with weight loss. So how do we usually define weight loss? Well, 5% or greater loss of body weight. So if you're looking at 100 pounds, that's like 5 pounds, and 130 pounds, that's 7 pounds. That's not a lot. So if you can imagine in your clinic and there's like 30 or 40 people in the waiting room, or you're in a residency program, and you're being trained to actually function in the real world. Unfortunately, the real world of generalist care or primary care requires you most of the time to see at least 30 people or more per half day. Then that means about 5 to 10 minutes per patient, right? So you're in a hurry, and then the patient comes in, and then there's a whole bunch of people in your waiting area who might require more than 10 minutes, and then the patient comes in and says, I lost 5 pounds. So what's your initial reaction? A lot of people will react, well, 5 pounds, I lose 5 pounds every day, right? And you think about all your patients who are between 20 to 40 years old who lose 5 pounds every day. So, and you say, well, that's not such a big deal. That just monitor your weight, eat well, and then come back to me. And sometimes if you're concerned enough and they're wanting something, then you give a prescription for the so-called appetite stimulant, or some supplement advertising itself as an appetite stimulant. And of course, the literature, and that's probably not going to help, but maybe you'll tell yourself, well, it's a behavioral kind of thing. They think they're getting something, and hopefully they eat more and their appetite improves because Many appetite problems are psycho-emotional or psychological. I mean, and not all of them, but you're hoping that for this particular case it is. And then you tell them to come back to you. Depends on how busy you are. So come back in about 2 months. Now, what's the problem with that? The problem with that is your patient is an elderly. And the reason why everyone in the elderly care field or the geriatric field is writing about it is because 5 pounds for someone who's 100 pounds or 7 pounds for someone who's 130 pounds is a big deal. Why? What's the difference? Well, one difference is you're 20-year-old or you're 30-year-old. There's lots of reasons why they can lose 5 pounds or 7 pounds. Most of it is because it's related to their work. They're very busy. They're on a diet. They're not eating well. You just look at their food diary and you ask them about how things are and what they're doing at work or at home. You can ask them if they're going to the gym, and you can easily figure out why they're losing weight. And then all you need to do is just advise them about lifestyle modification and healthy ways of actually eating and healthy ways of actually keeping yourself fit and exercising and ways of managing stress at home or at work. And that's the end of the story. Now, with the elderly, they're pretty much retired. They're at home. They're still prone to bouts of depression. That's why you have to screen for it. But they're not at work. The stress is different, and then they're pretty much eating the same thing over and over again. And it's easy to ask if there are any changes. And they're not the types who usually would go frequently to the gym because they want a fit body so that they'll look nice at work and outside of work. It's not that. And so when you talk to them, you realize that the usual stuff you think about when you're talking to someone who lost 5 pounds, who's 30 years old or 40 years old, doesn't apply to them. And then you start getting worried. If you go that far, sometimes if you're in such a hurry, you won't even try to probe deep enough to figure that one out. You're not willing to ask a lot of questions because you're in a hurry, and those questions are relatively simple. They're not even deep probing questions. The other thing is the very elderly is very similar to the very young. When they get sick, they don't have a lot of reserve to stay stable. Babies or toddlers, when they get sick, they can really crash quickly if it's a severe enough illness. For the elderly, it's the same thing. I mean, they don't have a 20-year-old body anymore. So any disease that is left undetected can progress really rapidly and cause a lot of problems, a lot of debility, or even death in a short span of time. And if you wait too long, or if it takes you too long to figure things out, then the possible treatments that you would usually offer won't be possible anymore because they're too weak, or their kidneys or their heart or their lung or the liver have deteriorated even further, far beyond what was caused by age and or their long-standing chronic problems because of the undetected new disease process which had caused the unintentional weight loss. It might not even be a new disease process. It might be a sudden worsening or a complication of a long-standing chronic disease, but you didn't pick up the sudden worsening or deterioration. It wasn't picked up because just the patient just lost weight. Now, a lot of times you won't even know that the patient lost weight because it's not the kind of thing we usually ask. Like, if somebody comes in with cough and cold and things like that, and you cannot run through 40 or 50 item review systems. All visits, if it's a primary care and you have like 30 or 40 patients per half day, would tend to be focused. You can easily not ask about weight loss, right? So one suggestion is, when you're dealing with the elderly, it's good to ask or screen for weight loss. You either ask it directly if it's related to their clinic visit, or you can ask it as a questionnaire while they're waiting in the waiting area or the waiting room of your clinic. Now, the other reason is even the patient himself or herself wouldn't find it significant. Sometimes they don't even notice it. The people who will see or notice that they lost weight would be the people living with them or their relatives when they visit, or family when they visit. But they themselves, many times, they don't even notice it. I mean, it's a very common thing. You don't need to be an elderly to know that that's actually what happens. Like even you yourself, you might lose 5 pounds or 7 pounds gradually in a span of 6 to 12 months. By the way, that's the way how unintentional weight loss is sometimes defined for the elderly. Somebody who's over 60 or over 65, 5% or greater weight loss in a span of 6 to 12 months. So you usually don't notice it yourself. So if you go talk to your doctor and you talk about constipation or some painful shoulder, you probably won't mention the fact that you also lost weight. You either didn't notice it or you noticed it, but as far as you're concerned, that's no big deal. You used to lose 5 pounds or 7 pounds all the time when you were a lot younger, when you were 30 or 25. Now, of course, things would be a lot different when somebody presents, is brought in by their kids and they look very cachectic. Now, the problem with that is you don't get to be cachectic in a few weeks' time. So that means the patient has been having problems for several weeks before the family visited the house and noticed the patient and got worried, or the family decided that, just telling mom or dad to eat more every time they visit during the weekend is not working, and they're actually very thin already and cachectic, and they got concerned, so they brought the parent to the doctor. So cachexia, of course, or the cachexia syndrome, is weight loss greater than 5% within 12 months, but you're thinking of something that eats up your body. Chronic illness caused, like, cachexia can be caused by cancer or a fairly severe chronic obstructive pulmonary disease or a kidney disease. Of course, it's not just weight loss. You're thinking of fatigue or anorexia or decreased lean muscle mass or lean body mass, decreased muscle strength, and low albumin levels and laboratory abnormalities. It's much more than just plain unintentional weight loss. It comes with all sorts of things. Usually, you need about 3 at least of those I mentioned to say that it's cachexia. Actually, you don't even need to memorize most of them, because, if you see it, once they bring themselves or they bring their parents or their grandparents to your clinic, it's pretty obvious that it's cachexia, and you don't need to go through the tools to figure it out. Now, of course, the tools are meant to help you figure out cachexia before it becomes severe enough such that you don't need the tools anymore. When you talk about weight loss, all the causes will probably cover like 70% of your entire textbook. I mean, I don't even need to tell you what the differentials are. It's a lot. It can be anywhere between, you have dementia or poor teeth, or you're depressed, or you have an emotional problem, you're not eating well, or you have a gastrointestinal problem, having diarrhea, you're having problems swallowing food. Of course, somebody gave you medication and the medication is actually making you lose weight or lose your appetite. You are very weak and it's really difficult for you to eat or go to the grocery or feed yourself. Your taste has changed much with age, or because of medication, or because of your other chronic medical problems. And if things don't taste well, why would you eat, right? If you get a pneumonia and you're an elderly, you usually get sicker, and if it's a 5 to 10 day bout of pneumonia, and you get sicker and you don't get better faster, you need more days to get better, and you're not eating, and of course your body is fighting off the infection, and there's a lot of inflammation going on systemically in your body. So by the time you have gotten over the infection, you probably lost a lot of weight. So that's an acute medical problem. Anyone who gets hospitalized for anything, of course, because they're very sick, the feeding goes down, the appetite is not there, and they're giving you a lot of medications, and you're too sick, and you're on an IV, but the IV only contains just a very small amount of glucose that's not even going to sustain you. But of course, it's helpful. I mean, it's nice that it's there. And so by the time you got better enough and you can get out of the hospital, usually if you're the elderly, then you're a lot thinner. You've lost a lot of weight. Of course, if we're doing primary care in general practice and we're dealing with a whole bunch of stuff, it would be nice and helpful for us if we have an easy algorithm in approaching the general case, right? And for one thing, we are not in a position to read up on all disease processes, even the most common ones, and be up to date in everything, right? And on top of that, we're trying to do things really fast, between 5 to 10 minutes. So it would be nice if we have like an algorithmic approach, like, do this, step 1, 2, 3, 4, 5, or order this test or don't test, and wait it up, follow up, and then if this happens, then do this. I mean, that's great. That's usually how we function. The problem with unintentional weight loss is you won't find those things simply because the differential diagnosis is spread. It's so many, and there's not just 1, 2, or 3 or 5 main things. I mean, it's a lot. So if someone attempts to create that kind of algorithm, it's going to occupy like a huge chart. And of course, the more complicated it is, the less useful it becomes, right? So that's the reason why we like back pain. So back pain, you're 40 years old. Okay, so these are the steps. First, you do this, and then order this or give this, and then observe it, and then they come back after 1 week or 2 weeks, and then you do this if this happens. That's pretty much how it works. You can't do that with unintentional weight loss in the elderly. But then every now and then you actually see some algorithms and decision-making flow charts or algorithms for involuntary or unintentional weight loss for the elderly. And it looks like it only occupies 1 page or like 3/4 of a page. That's not very complicated, right? Now, the trick is actually to trim the major branches. It's complex, but then you don't get to see the small branches. For example, it says complete history including this, this, and this, and this. And then it stops there. And then it assumes that you actually did that well. It doesn't give you all the branches or how you should go about doing it. And then it assumes that you actually will pick up suspected diagnosis based on your history and physical easily, or you don't see a suspected diagnosis. It assumes that decision is very simple. Of course, it's not. The actual decision making that happens in that decision point is very complicated. It's still useful because, it actually summarizes a clinical article. That's pretty much what it is. So you read the article, and then it gives you this algorithm which just summarizes whatever is written inside. Now, just like the clinical article, it's not simple. Or you get to see something like do history and physical, and then you see a diagnosis, treat underlying diagnosis, or choose a good test to figure it out. But then it stops there. It doesn't mention that you actually have a whole slew of possible differential diagnosis, and you have a whole bunch of branching decision points in order to figure out what diagnostic maneuvers or interventions you need to do and test to order so that you can come up with a good list of possible or most likely diagnoses. Now, it also assumes that once you trim everything down, you'll only end up with 1 or 2. But then the reality is in the elderly, you can probably end up with 4 to 5 or 6. So that's the first part, the simplified, try to figure it out, get the history and physical exam and such. And then the middle part just goes straight for, well, if you don't know and you can't figure it out by history and physical examination, do all these tests. Okay, now what about the laboratory tests or the diagnostic tests? We always ask about that, but what I can tell you is, again, the most important thing is look over your medical records. What does the patient have? What are the chronic medical problems that he or she has, which might be causing complications or which might be worsening and contributing or causing or be one of the causes of the weight loss? Or is there anything that can easily happen to this patient, knowing that this is the patient's medical background or history? And then look over the medication chart and the other specialist who saw the patient. Did he visit another specialist 2 weeks ago or a month ago? Is your medication list on your chart up to date? Did you read through the letter of the specialist who was assisting you with the diabetes or with a heart problem? Did he start any new medication? It might be something as simple as he actually added a diuretic to the patient's regimen, and the patient actually hasn't been drinking a lot and lost a lot of weight, but it's actually dried out. So, if that's the case, then you don't need to order a whole slew of tests. Just order something very focused if that's the case, right? So anyway, when you look at charts, especially when you look at short, quick references or textbooks for primary care or general practitioners or family medicine doctors, usually it's a short chapter and then tells you these are the usual tests that you might want to consider, or these are the usual tests that you would need to order. And then it gives you a list. It's not the same list for everyone. If it's a conservative writer or country or medical community of primary care doctors, they'll probably give you a shorter list. If it's a more resourced country and they don't want to miss anything, especially if they're in an environment that's where the lawyers are very active, then they'll probably give you more. And so the list can include something like complete blood count, a blood chemistry or basic metabolic panel, liver function tests, kidney function tests, thyroid tests. You can have something for inflammation like ESR sed rate, or what they call like erythrocyte sedimentation rate. So that's the ESR, or a C-reactive protein. If it's not that expensive, of course, some of these tests are expensive. You just make do with the cheaper ones, like order the sed rate and skip the expensive C-reactive protein, especially if you're in a country with very limited resources, or your patient doesn't have enough money to pay for all the stuff you want to do because you're not really sure what the problem is. So you can have glucose tests or fasting glucose tests, lactase dehydrogenase, and then you go through the more expensive stuff like protein electrophoresis, which you probably won't order right off the bat. Even ferritin can be fairly expensive for low resource communities. Urinalysis for the kidney, and you can even go for fecal occult blood. You're looking for cancer. You can even look through the patient's chart. He's above 50, and you check whether you've done any cancer screening tests lately, right? So you look through the results of your previous labs and figure out whether all the chronic medical problems for the patient are fairly stable, or if you've been having problems with some of them, which might be contributing or causing the weight loss. So my advice is, don't just do the usual short history. You're in a hurry, and then, oh no, I don't know what the deal is, and it's an elderly, so I have to check everything, and then you start ordering. It will cost you a lot. It will cost your patient a lot, or it will increase his insurance premium if he has private insurance, and it will be very burdensome for your patient especially, or for the system, and that's not what you're there for. Primary care, family medicine, general pediatrics, cost-effective care to manage the most common problems of the community, limiting the need to refer to the entire planet of specialists, right? So of course you need to refer every now and then. We have our limits, of course, obviously. So like another example is the patient just told you that has been having paroxysmal nocturnal dyspnea aside from the weight loss. So instead of ordering all sorts of tests, maybe just focus on the heart for a while, right? Or everything's fine except that he cannot swallow food because it hurts his mouth, and then you look at his mouth, his teeth are bad, or the dentures need some checking. So you don't need to order sed rate and protein electrophoresis and thyroid function tests and all sorts of things, especially if the problem started during the time the patient complained about the teeth, right? So fix that, and then if everything's back to normal, then why order diagnostic tests for the weight loss, right? Now, these tests will still come up if you've done all those things and you're not sure yet. So what you'll notice is these things are trying to check on the possible causes. I mean, you cannot check every cause, but it's trying to check the most common ones. And the only thing that's lacking here would be, you don't have a whole bunch of cancer screening tests, but you're worried about cancer. So, that's easy. You look for anything that will tell you if there's any particular cancer you have to be worried about. You look at the chart, see whether patients' cancer screening tests are up to date, because you do those things even for patients who are not experiencing anything. Those are screening tests, and the patient is experiencing something, so definitely you need to do those things. And you probably won't be satisfied with just a negative stool occult blood test. You'll go for, because you know it's not that sensitive, and the patient's not asymptomatic, the patient's actually losing weight, and you're worried. And it's been happening already for after 2 to 3 visits, and you're more concerned right now. You thought it will get better, but it's not a simple problem. So maybe just go for the colonoscopy and other things, even if the patient really doesn't want the discomfort. Now, probably during that time, the patient is also worried, so he'll probably agree to it. Now, for the elderly, like 65, 70, or 80, you have to sit down and talk to them. Like, for example, it can be colon cancer, it can be something else, but there are financial considerations and things like that, and the patient has a lot of comorbidities, and the patient will say, well, what will you do if you find cancer? Will I survive the treatment? And you'll say no. And how is it an easy thing? Well, you'll say, well, this is what they do. And the patient says, well, maybe we'll hold that for a while. So that's informed decisions, and then you tell the patient, okay, so if we don't do this, this is what we might miss. Are you okay with that? And the patient says, okay. So that's informed, shared decision making. So increasingly, as you get older and older patients, the role of shared decision making increases, right? So now going back to the algorithms, like I said, simplifies the first complicated part, simplifies the most complicated stuff, like try to get the history of the physical exam, try to come up with a good diagnostic maneuver and process or procedure so that you don't end up ordering a whole bunch of stuff, and so that you can efficiently get to the diagnosis. And then after that, it says, well, if you cannot figure it out, then do all these tests. So when you look at this algorithm, what you'll probably do if you're in a hurry is you'll skip through the first part, and then you'll say, well, I'm in a hurry. I asked 6 questions and tried my best to figure it out. I cannot figure it out. It's just easier to write the order for the lab test and the diagnostics test, so I'll just go ahead and do that. Well, that's the most expensive thing you'll ever do, and you probably wasted a whole bunch of stuff. Well, if you do that, first of all, you didn't really follow the algorithm, because the algorithm is telling you to do a decent job in terms of history. It actually tells you do a good, complete, decent history and physical exam and try to figure it out. And then, if you cannot figure it out, do all these tests. That's what it says. It doesn't say do a really quick question and answer portion in a really quick physical exam, and if you cannot figure it out, do all these tests. That's not what it says, right? So now, if you try to do that because you're in a hurry and you're trying to finish the entire visit in 5 to 10 minutes, so you'll just rush through the first part, and then it's a lot easier to just order a whole bunch of stuff. And I can guarantee you're probably wasting a lot of resources by doing that. You probably don't need half of what you just wrote if you did a decent history and physical exam. Now, the thing that should get you worried, and the thing that tells you that it's nothing that you should be too relaxed with, is the big C, cancer. Because, if you have cancer, you lose weight, and you lose weight progressively faster and faster. The older you get, the more likely it is that you might end up with cancer, right? You're anywhere between 10 to 15 times more likely to have cancer compared to someone who's like 20-year-old or 30-year-old with unintentional weight loss. Now, the other problem with the algorithm or those kinds of easy ways of going about doing things is because it's really difficult to create an algorithm if you're dealing with psychosocial problems, which are just as common and significant as the usual organic or clinical ones we're used to in medical school. And of course, the way we're taught in med school, or even in residency or training programs, or even the way our books are written, everything is all about most of it is all about the clinical organic stuff. The psychosocial part is, it's there, but it's not a lot. And even if they attempted to write more about it, your instructors or professors, because they were trained in the old way, won't pay attention to it. And the way they practice and the way you watch them while you're doing clinical training or hands-on training, it seems like the psychosocial part is not that important. The problem with old people losing weight, well, everything else that's not organic becomes very common and very important. Simply put, anything that you usually don't think about that prevents them from eating. So it could be the taste, it could be the mood, it could be access to food, it could be weakness, all those things, right? If you're in a poor part of a developed country, the rural area of the United States or Canada, or you're in a less resourced country, especially in the poorer part of the less resourced developing country, then you're dealing with other social factors which are pretty common and pretty significant, even in the elderly, or especially in the elderly, like financial constraints. They're not working, they're living off government assistance, or their very minimal monthly retirement pay. Alcoholism, impairment in functionality. They're alone. Most of their relatives or family their age have died already, so that's a clear setup for emotional or mood problems that would interfere with your appetite and can even lead to a significant depressive disorder. That's why when you do your geriatric assessment, or when you look at your geriatric assessment forms or guides, it's not just looking for memory problems or dementia or mood problems. You have your geriatric depression scale, and checking for the eyesight or checking for the vision if it's already blurry and the patient's just not telling you, or the hearing is already bad and the patient thinks it's part of old age, but you can actually do something about it and it will greatly improve their life. Or checking for incontinence, or the usual stuff that you should look for, in addition to the stuff you usually look for if you're dealing with someone who's only 20 or 30 years old. The extra stuff you need to do when you're doing a health maintenance management kind of visit for your patient. Usually those annual so-called executive checkups or annual health maintenance checkups happen for anyone. So from 20 to 70 to 60 every year. On top of that, then you'd have your geriatric assessment stuff. So now sometimes some articles give you like the possible causes, because if the causes are many, then you'll say, well, I need something. I can't work with like 50 or 60 different differential diagnoses. What's the most common? And they'll list the most common chronic problems in the elderly, like cardiopulmonary or kidney disease, endocrine disease, and neurologic disease. Okay, so those things range from anywhere between 2 to 4% to about 10 to 12%. Pretty significant. It depends on where you are and depends on the community. That's the reason why it's a huge range, like 2% to 10%. That's huge, right? So depends on where the survey or the data is coming from. In addition to that, then you have the psychosocial or emotional or psychological problems and alcohol problems, and they're pretty significant. You're dealing with 8 to 9% to as high as maybe 25% for all the psychosocial, social, emotional, psychological factors we talked about. Now we go to cancer or malignancy. So that's like 19 to 20% to about 35 to 36%. So that's pretty high, right? And that's the reason why you should be more concerned. You should be more concerned if the one who is losing weight unintentionally is an elderly, and you cannot be as relaxed as you will be if the one complaining to you is a 20-year-old or a 25-year-old. Of course, it doesn't mean that people who are 20 years old or 30 years old won't come down with cancer. You still have to figure that one out. So what will happen is, you treat the most likely things, but it doesn't work. And in several weeks' time, depends on how fast the cancer is, in several weeks' time or in a few months' time, the person just keeps on losing more weight and getting more cachectic. Hopefully, it doesn't go too far before you realize that you really need to do something else and get to the root cause right away. Because missing that diagnosis in someone who's 20-year-old or 30-year-old can also be very disastrous. That can mean the difference between getting cured or not, right? Because there's a delay in diagnosis. Of course, it doesn't mean that you have to do like a Dr. House, if you're familiar with the TV show, like, what's the differential diagnosis? And then he writes it on the whiteboard. It's like writes down all sorts of weird diagnoses, maybe like 6 to 10 of them, and then starts ordering different diagnostic expensive tests for each one of them. Can't do that in real life, even if your country is very rich, and I don't think there's any developed country where you can do that for everyone. Now, if you have a patient who's a multimillionaire or a billionaire, well, that's a different story. But, as primary care or generalist providers, we're not too interested in that population group, obviously. Sometimes you are also given a few pointers, like, things that are so obvious, or things that you can, if you're really in a hurry, this can probably help you. Like, for example, having painful teeth or painful mouth or gums, or having problems eating, well, take a look at the mouth and ask about the mouth and the gums. Maybe that's where the problem is, or figure out whether there's something happening with heartburn or reflux disease or hyperacidity or stomach. Now, if they're short of breath all the time, well, that's very common in the elderly. Figure out whether their chronic disease that you already figured out, hopefully, is getting worse, or they're coming down with a new problem, like, their heart failure is getting worse, or their lung problem is getting worse. If they come down with fever and they have body aches all over, or they're weak, and then of course you think about infection. Now, you have to always be concerned about infection, especially if you're dealing with the very elderly, 70 years old, 80 years old, because they can come down with really bad infections without fever. Their white count might even look not too bad, because their immune reaction to the infection is a lot different from someone whose body is going to attempt to fight off the infection well. Someone who's like 20 years old, 30 years old, mobilize your white blood cells, get the temperature up so that you can fight off the infection. It doesn't work anymore if you're like, 70 years old or 90 years old. No, if you have like bloated abdomen, and that's the reason, bloated belly, and that's the reason why you're not eating, because you feel full, or you feel sick to the stomach and you feel bloated. That's a very common thing. Gastrointestinal problems are very common for the elderly. That's such an easy thing. So you keep an eye on those things that can make your problem simpler, right? Now, on top of that, the older you get, the more likely you'll have all sorts of chronic medical problems. And unlike a few decades ago, each medical problem right now usually gets 2, 3, or 4 medications. Like in the really old days, before we were all born, they were just using 1 medication for diabetes or hypertension. And then later on, when we were in school, they were using 2 medications. Now, a lot of people are walking around with at least 3 or 4 for each of those. So that's, if you have both, that gives you about 8 or 9 pills to swallow. Sometimes you actually get sick with the amount of tablets that's entering your stomach. That's not to mention the vitamins and the supplements and the minerals and everything else that you want to take, right? Now, of course, the medication, well, it can cause all sorts of things. Like they can't sleep, and then, they don't have a lot of money, so you end up giving like diphenhydramine, which we're told not to give. You can look at the previous lecture about sleeping disorders if you're interested in diphenhydramine and sleep problems or insomnia. So we gave the diphenhydramine, and then they get all sorts of side effects, and one of them would be dry mouth. So if you tried eating with very dry mouth, it's no fun. Like, swallowing is no fun. Having food inside your mouth is also no fun. Like a lot of medications also can cause poor appetite, or alter your appetite, or decrease your appetite. Your taste and smell can be altered by medication. Of course, the COVID can alter your taste and smell also, and it can last for several months. But even before COVID, a lot of medications can alter your taste and smell. And you have swallowing problems, causes you to have upset stomachs, or epigastric pain, or dyspepsia. And then you'll end up not eating because of that. It's either dysphagia or dyspepsia or other stuff that's related to your upper gastrointestinal tract that's preventing you from eating. You can get nauseous, or you feel like vomiting. You're actually vomiting all the time because of the medication they're giving you. So it's also good to think about medications. Have you taken anything new lately? And then you try to figure out whether that coincides, or it's like just 1 week or a few days before the patient actually started having problems that prevented them from eating, or before the patient started losing weight. Of course, the time when the patient started losing weight can be a problem, because, like I said, not everyone notices it. But if they notice it, then you ask, well, did anything change during that time? What about medication? Did someone give you a new medication? So that's the reason why for the elderly, every time you start a medication, even if it's something that looks simple, like for uric acid, or for blood pressure, or for sleep, after a few days or weeks, you ask them, either by telemedicine, or you make them follow up with your clinic, because you want to first figure out whether it's working, and you have to figure out whether it's causing problems, right? So you have to be careful with problems related to medication you start, especially in the elderly. Things we don't usually worry about if we're dealing with a young adult, we should worry about when we're dealing with someone who's over 60 or over 65. There's another listing that's very popular, and it can be helpful for some of you. It's very popular. I mean, even during our time in med school, it's Meals on Wheels. Yes, it's MEALS ONWHEELS. Meals on Wheels. So that's medication, emotional problems, anorexia, alcoholism, and then L is late life paranoia, S is swallowing problem, O is oral factors like dentures or dental caries and such, N is no money. Well, they have to have an N, I guess. So N is no money and or nosocomial infections, and then W is wandering around, so that you have dementia. It should be a D, but you can't. There's no D in Meals on Wheels, so wandering, dementia, and then H is hyperthyroid or hypercalcemia or hypoadrenalism, and then E is enteric problems or intestinal problems of E, enteric, intestine, bowels, and then another is eating problems like unable to feed themselves, and then L is low salt, low cholesterol diet, and then S is shopping problems, unable to shop or do grocery, and stones like cholecystitis. Some of you might find it useful, I guess. For me, it's actually hard to memorize because some of the letters, obviously, they really try to squeeze it onto the meals on like wandering. So that's dementia. Why not the D? Because there's no D, like financial, no money, like things like that. But it's a long list, and you can work with it. Just you're looking at your patient, and then meals on wheels are running through your head just to make sure that you don't miss the common ones or you don't forget too much. Obviously you cannot run through the entire differential, but at least you've thought about these, the meals on wheels categories or differentials. Now, what's the management? Okay, so again, same with the sleep disorder lecture. You don't just go to the management right away. Like the patient comes in and you're very complete in your assessment, and you notice that the patient lost weight, and then you say, eat well, keep a food diary, and this might improve your appetite, and give an appetite stimulant, and then see you in 2 months. Don't do that. And at least make sure that you're satisfied enough that there's nothing warning you that there's something really bad going on, right? Now, obviously, the appetite stimulants are not going to be very effective because there's no use in stimulating the appetite if the psychosocial or psycho-emotional problem, or the financial problem, or the progressively worsening chronic disease that was there before, or that is new or undetected, is not managed, right? So it's not really proven to work. And of course, you have different medical problems, and so you have different mechanisms or causes of lack of appetite. One chemical or one drug is not going to fix all those, right? It's not like an opioid for pain. Even opioids cannot manage all kinds of pain, like take neuropathic pain, for example. Same thing here, even worse here. The appetite stimulant is not going to improve food intake and appetite for a lot of people, right? So if you're talking about evidence-based. Now, there are certain medications which we use for something else, and then we notice that the patients are gaining weight. Like when mirtazapine first came out for depression, for example, and we were in training them, and people were gaining weight, and doctors started talking about it, and there were several concerns. Actually, the first concern was like, we have to be careful if we're dealing with someone who's obese or has diabetes or has cholesterol problems. That's the first thing that circulated during that time. And then later on, the thing that circulated is, well, maybe if the patient has poor appetite and is not gaining weight, maybe we can give it to them, because the weight gain seems to be pretty significant. That's how it works. It's almost the same story as bupropion, the smoking pill. That one happened a few years before mirtazapine. We were using it. It's one of those newer, so it's like after Prozac or fluoxetine, a whole bunch of the drug companies or the industry saw a huge market. Everyone's depressed in the developed countries, so let's start giving them all pills. I mean, some people even said, just put it in the water. Of course, the big question that nobody tried to answer is, why is that happening? It's the quick fix mentality, right? So, and if we're a busy doctor and we're just after, just give the pill, make the industry happy, and make the med rep happy, we will go along with it. Well, actually, you shouldn't go along with it. I was just kidding. So, and it's fairly new, so we started giving the new ones, and fluoxetine is fairly old, and usually when new ones come, they try to bash the old one, which is more affordable, but they're selling the new one, and this is better, the side effect is better, and things like that. But people noticed that the depressed people who are trying to quit smoking can quit better or has less problems after they stop smoking compared to the general population. So suddenly it's the same drug, you put it in a different box and you give it a different name, and it's the pill for smoking cessation. So same thing with this antidepressant mirtazapine. So use it for weight loss or weight problems as an appetite stimulant, because the side effect is they started eating more. So again, as far as the clinical stuff is concerned, first try to figure out what's happening. Don't just focus on one cause. If it's the elderly, it's usually a whole bunch of problems. It might have started with 2 or 3 or maybe just one cause, and then it got worse, and suddenly that one cause triggered 2 or 3 more causes, and then that triggered some complications, and by the time they reach you, you might be dealing with a slightly more complex thing. So You don't need to figure out everything, but at least the major players. And then if you know the major players or the major causes or the major factors, then you can intervene. It's usually a combination of medication, monitoring, behavioral stuff, trying to get some assistance for the social stuff or the financial stuff, and trying to address any kind of psychological issues or concerns. That's pretty much how it works. Now, for referral, well, we're not specialists. Like, we know a whole bunch of stuff in different areas, but we're not a specialist in each and every area. We don't read the journals of each and every specialty field or subspecialty field. What we're supposed to do is take care of, hopefully, at least 70% of all the problems of the community, and maybe with the remaining ones, coordinate or co-manage with the specialist if it's really difficult. Now, for the referral, you refer if you're stuck, right? You did the screening test, nothing's showing up. You're stuck and you're worried. Before it was just 7 pounds. Now you're looking at someone who just lost another 7 pounds. So that's like 14 pounds already. So, and the patient really looks thin. He or she was thin to begin with. And all the history you sat down, and nothing is really telling you what the problem is. So you do the referral. So who do you refer to? Well, depends on your best educated guesses. It could be 1 or it could be 2 or 3. Like, you're thinking it can be a gastrointestinal thing, and then you're kind of stuck with a workup. Then go for a gastrointestinal workup or gastroenterologist. And then you're thinking, well, maybe it's a psycho-emotional thing or a mood thing, except that you don't have like 1 hour to figure things out, and it's very subtle. Then go for a clinical psychologist or a counselor or a psychiatrist. Or maybe it's a metabolic thing that you're not sure of, and you've done all the basic workup. Maybe you're missing something, and then ask the endocrinologist to help you out. So it depends on what you're dealing with. Now, for the cancer, sometimes primary care doctors, they're stuck, they don't know. So they go for the stuff that can be, like, they send the patient to the oncologist and ask the oncologist, well, I've done all this screening test, and we're obviously scared about the cancer, like if I'm missing a cancer. So that's the reason for the referral. Of course, oncologists don't like that referral. It's like, we don't know, all the tests that we did, all the basic cancer screening tests is negative, go figure it out. But what else can you do? At least their line of testing will be guided instead of us doing all the cancer screening tests available in the entire planet, right? So that's how the referral works. We do as much as we can, but if it's getting worse or we're getting concerned, or before it gets there, especially if we've done everything that's expected of us and it's not really going anywhere as far as pinpointing the cause or causes, or the management is not working too well, then the referral is also part of the management process as far as primary care or generalist medicine is concerned.